Good evening, everyone. I'm Dr. Chandrika from Indira Gandhi Institute of Child Health, Bangalore. This is our beautiful institute. It's a tertiary care pediatric hospital. I'm going to discuss about the poor rectal analgesics in children, the route less traveled. As far as I'm concerned, I would like to say frankly here that this route is less traveled by me. The reasons I'm going to narrate in the following slides. What is the importance of giving perioperative analgesia? So if you give superior analgesia, it results in coma patients. So it will be helpful for the parents and the caretakers to take care of the child. Perioperatively, it upstunts the stress response. It gives hemodynamic stability. It reduces the MAC requirement. It decreases the requirement of other analgesics agents, especially the opioids, leading to smooth emergence and fast recovery. It also improves GI function and helps in early return of appetite, fast tracking, early discharge, and helps in ERAS protocol. Whenever we think of giving analgesia to children, we should always think about multimodal analgesia. What is the advantage of multimodal analgesia? In multimodal analgesia, we are going to combine two, three different drugs and different routes of administration so that the dose of each individual drug is reduced, thereby reducing the adverse effects of each individual drugs. When you think of multimodal analgesia in children, we can combine opioids like morphine, fentanyl, remifentanil, non-opioids like paracetamol, NSAID, and others. The others includes ketamine, gabapentin, and also dexmedetomidine. And we can combine regional anesthesia also like central neuraxial block and peripheral blocks. Whenever we think of giving drugs, we should know the bioavailability of that drug in the route of administration. What do you mean by bioavailability? Bioavailability is nothing but it's a fraction of the drug which reaches the systemic circulation in active form. Naturally, it depends on the route of administration. This chart or the table is showing the bioavailability of drugs through various routes. As you can see in this table, 100% bioavailability is there only for drugs which are given intravenously or intraosseously, followed by intramuscular subcutaneous route, which has a bioavailability of 75% to less than 100%. Oral, it's only 70 to 80%. As far as rectal route is concerned, the onset of action is 30 to 45 minutes and the bioavailability is variable. It is 30 to 50%, and I have written here less than 100% with a question mark that I am going to explain in the slides later. And we can give drugs through inhalational route and also transdermal route. The drug what we administer through rectal route is called suppository. So the word suppository came from Latin word supponere, that means substitute. So it's a substitute for other routes of administration. Where all we can give per rectal administration, or what are the indication for per rectal administration of the drugs? Those drugs which are having poor solubility or poor stability and permeability through oral route, those drugs can be given through rectal route. Then patients who are kept on NPO, like in the immediate postoperative period, who cannot take orally, we can give rectal route of drugs. Patients having PONV, postoperative nausea, vomiting, and patients with swallowing difficulties like very small children and children with mental retardation, CP children where they cannot swallow, and also in unconscious patients, we can give rectal administration of the drugs. The most advantage of the rectal route of administration is the ease of administration. It doesn't require any training. So it can be introduced by untrained personals also, like caretakers, parents, anybody can put rectal drug. And also it helps in emergency situations, like if the patient comes in ER with status epilepticus or febrile convulsions, we can put the suppositories before establishing the other routes of administration. Let us discuss about the factors which affect the absorption through rectal route. Most important thing is the formulations of the drug, whether it's in the liquid form, gel form, or solid form. If it is in the liquid or gel form, it gets absorbed very easily because that disintegrates or dissolves in rectal mucosa, dissolves in rectal fluid and then gets absorbed through rectal mucosa. But most of the drugs what we use usually will be in the form of solid, those suppositories. So for those suppositories or solid form, that has to first disintegrate in the that has to get dissolved in the rectal fluid first and then get absorbed. It also depends on the volume of the drug. So if you give more volume, there are chances of drug getting expelled. So if you want to give liquid, the maximum volume what can be given in pediatric age group is only up to 5 ml. Even the solid or suppositories, if you put a larger one, there are chances of expulsion. So that's why all the pediatric suppositories are less than 1 gram. It also depends on drug concentration because I have already mentioned the bioavailability is less. The initial bolus dose will be more compared to other routes of administration. Again, presence of fecal matter, pH of the rectum, and the time available for absorption, all those factors will interfere the absorption through rectal route. But most important part is the site of the delivery or the site of the deposition of the drug. So if you put the suppository in the higher part of the rectum, that is superior hemorrhoidal veins, that drains into portal circulation. So because of that, it goes through first pass metabolism in the liver. If you put the suppository in the lower part of the rectum, that is middle and inferior hemorrhoidal vein, they drain into systemic circulation. That's why I have written there 100%. But most of the literature says that the absorption from the lower part of the rectum is very, very low. Then the most important aspect is acceptance. The patients and the parents should accept the administration of the drug through rectal route. So after knowing all these things, what do you think about the bioavailability of the rectal route? Always we should remember that the absorption is erratic and the bioavailability is variable, and again it depends on the site of deposition, which I have already explained. So do we have to take any precautions whenever you are putting rectal suppositories? Yes. In neonates, especially preterm neonates and term neonates, we have to be very careful because they have a very thin and they have very thin mucosa, which is very friable. So if we are not careful, we are going to cause breach in the mucosa. So that's going to cause infection and rectal abscess. Likewise, in immunocompromised patients also, we have to be careful. And if there is any history of trauma, local trauma, you should not give suppositories in these children. So let us discuss something about the analgesics most commonly used in pediatric age group. As far as analgesia is concerned, the most popular drug is paracetamol. So rectal paracetamol is given in the dose of 20 to 40 mg per kg body weight 8 hourly. If the weight is less than 10 kgs, then the dose is 15 mg per kg. And the maximum dose what you can give in a day is 100 mg per kg in children, 75 mg per kg per day in infants, and preterm neonates it's 40 mg per kg, and term neonates it is 60 mg per kg per day. The next most popular drug is NSAID. Ibuprofen suppository is not available in India, but it's available in Western countries. So the dosage is 10 mg per kg 8 hourly. And in India, we use, apart from paracetamol, diclofenac sodium. The dose is 1 mg per kg 8 hourly. So where all we can use rectal analgesics, or what is the perioperative use of rectal analgesics? It can be used to give preemptive analgesia. That is, preemptive means before the patient experiences the pain, we are going to break the pain pathways. So if at all, if you want to use it for preemptive analgesia, it has to be introduced at least 45 minutes to 1 hour before induction of the anesthesia. So it has to be given in the pre-op holding area. It can be used for perioperative analgesia as a method of multimodal analgesia. So if we want to use for perioperative analgesia, it can be introduced after induction and intubation and once you settle the patient. It can be used for post-operative analgesia. So if at all, if you want to use it for post-operative analgesia, the drug has to be deposited at least 45 minutes before extubation so that by the time the child gets extubated, the effect would have set in. Let us go through few literature review, what they say about the rectal route of administration of drug. So this is one such literature which is published in Advanced Drug Delivery Reviews, which is published in 2014. They have discussed about rectal route in 21st century to treat children. So what they have concluded, they have said that the rectal route is usually better known for its disadvantages than its advantages. The main disadvantage are introduction of solid unit in rectum leading to poor acceptability and compliance, low absorption capacity of the lower rectum to some drugs, and the high inter-individual variability of the drug. Bioavailability mainly depends on how the dosage form is inserted. I have already explained about the formulation. There is one more article published in BGA in 2000. They have studied the pharmacokinetic of rectal paracetamol after repeated dosing in children. They have given paracetamol suppository 25 mg per kg every 6 hourly post-operatively for 5 days. And they have told that they have seen the plasma, serum and saliva concentration, and they have told that time to reach 90% of steady state concentration was 8.6 hours to 11 hours. There is one more study published in BJ 2008. They have done randomized controlled trial of duration of analgesia following intravenous versus rectal acetaminophen after adenotonsillectomy in children. They have given a rectal paracetamol of 40 mg per kg and intravenous 15 mg per kg, and they have concluded that rectal acetaminophen 40 mg per kg provides longer analgesia than intravenous acetaminophen. There is one more article published in Anesthesia in the year 2007. They have compared perioperative analgesia with rectal diclofenac, rectal paracetamol, and combination of both in children undergoing hernia repair. And they have concluded that children who received rectal diclofenac paracetamol combination experienced less pain, and they required decreased morphine. They required less morphine in the postoperative period. There is one more article published in Paediatric Anaesthesia 2008, where they have compared the pharmacokinetics and analgesics effects of IV paracetamol with rectal paracetamol in children undergoing major craniofacial surgery. They have concluded that IV paracetamol proved to be more effective than rectal paracetamol, and due to higher initial and better predictable plasma concentration, children receiving paracetamol intravenously experience less distress than those receiving paracetamol rectally. This is one more article published in 2016. They have compared effect of preemptive intravenous versus rectal acetaminophen on pain management after inguinal herniorrhaphy in children. They have found that patients receiving IV form had higher sedation level in the recovery room and lower pain scores during the first postoperative hour. This finding is acceptable since acetaminophen suppository has unpredictable bioavailability. So what happens if the children have undergone anorectal surgeries? So those children who have undergone pull-through for Hirschsprung's disease or imperforate anus, will there be any change in the bioavailability if we put rectal suppositories? So there is one article published in Journal of Pediatric Surgery where they have seen the bioavailability of rectal acetaminophen in children following anorectal surgeries. That was published in 2020. So they wanted to establish, or they wanted to see what happens after after intestinal anorectal reconstruction. So will there be any alteration in the vascularity which will influence the absorption? So what they have concluded, they have told that the bioavailability of rectal acetaminophen might get altered after major anorectal surgeries in children. That's maybe due to the alteration in the vascularity. Hence, the serum concentration of acetaminophen was above toxic range in these children 4 hours after the loading dose. Rectal paracetamol should be administered with special caution in infants with history of anorectal surgeries. And they have told that repeated dose of rectal acetaminophen may cause the drug blood concentration to reach the toxic level in these patients. So if you receive any patient who has undergone pull-through coming for any other surgeries, be careful with the rectal paracetamol. Literature says that if at all we want to use the rectal paracetamol, we have to reduce the dosage, or it's better to switch over to other routes of administration. So these are all some of the articles. So we have gone through all these articles. After looking all these through, looking through all these articles, what is the take-home message you think of? I would like to say that rectal route is usually better known for its disadvantage than advantages. So we should be beware of the fact that there will be erratic absorption and hence bioavailability. With improvement in drug formulations and better acceptance, this route may gain popularity in future. Finally, before ending my talk, I would like to leave it to the audience to decide whether they want to travel in this route or they want to take a different route. It is up to them. Thank you.